Do is we're going to go over how to do the 8 measurements you have listed there on your sheet. So we're going to be doing neutral calcaneal stance position, relaxed calcaneal stance position, subtalar joint range of motion, forefoot to rear foot deformity. Okay. We're going to do ankle joint dorsiflexion, first MPJ dorsiflexion. We're going to do limb length discrepancy, and which one did I forget? Frontal plane leg deviation. I forgot that last time too, but obviously that one's very important to me. Alright, so we're going to go over all those. And the way I'm going to group it is into measurements that you can do with the patient on an exam table as opposed to the stance measurements. Alright, it's a little easier to group it that way, and I think it's a little easier to follow some of the logic in what we're doing. Basically, you can use 3 different tools to obtain the measurements we need, and 1 tool for limb length discrepancy. So you need a tape measure to measure limb length discrepancy. Otherwise, you can use an OED, which I know one of your classmates has manufactured exceptionally well. So you can use an OED. You can use a tractograph, which I think everybody's obtained for free in some way, shape, or form. All right. This will be handy for radiology also, so you'll want to get one of those. And you can use what amounts to a gravity goniometer, or in this case, a roofer's level. You can get this at any Home Depot, Lowe's, any hardware store typically has these. All right, these are also handy. So
that one you see says angle finder on it. So
it does. Angle finder. You guys, you missed it. Angle finder. Good. All right. Very good. So first thing we're going to do is we're going to do some of the joint motions or joint ranges of motions, okay? First one I'm going to do is, since I have my patient supine here, I'm going to do ankle joint dorsiflexion, all right? And actually, Doctor, would you roll up that leg too? That way I can kind of show both sides. Thank you. I didn't think of that last time. I probably should. All right, so remember, ankle joint dorsiflexion, we're looking to see how much dorsiflexion the patient gets with you providing the dorsiflexion force. And how many degrees are we looking for normal? 10. Good. What are the circumstances under which we position the patient? In other words, what positioning do we need to apply to the patient to properly measure ankle joint dorsiflexion? Subtalar joint neutral, and when you say maximally pronated,
or locked.
Maximally locked. What's maximally locked? The front door, the mid-tarsal joint. Very good. We try and do that. All right? So here is the easiest way to get ankle joint dorsiflexion. I'm going to show you 2 ways. I'm going to show you a way with the patient supine. I'm also going to show you a way that I prefer with the patient prone. Okay? But basically, all we're doing is we're going to grasp the foot, and I'm going to pretty much put my loading force across the forefoot in what amounts to metatarsals 4 through 1, or 1 through 4. I'm going to go from least to most, or most to least. All right? Leaving my 5th mat head and 5th MPJ untouched. Now, why am I loading in that fashion? Why am I not applying any kind of a loading force to that 5th metatarsal head? Okay, elaborate. That was true. Maybe you could clarify. No, maybe not. Okay. Maybe not. Give up so easy. So, because that's what you're going to measure, so maybe we could figure that out ourselves. What are our 2 reference lines when we check for ankle joint dorsiflexion? All right, midline of the tibia. I don't know that I'd say midline of the tibia, but I would say bisection of what with respect to the leg? It is a vertical bisection, and a vertical bisection of
the
lower third of the leg, and where? Lateral, medial, anterior, posterior. You have 25% chance of guessing this right if you don't know. Lateral, very good. Bisection of the lateral, lower 1/3 of the leg is one reference line, right? Lateral, lower 1/3 of the leg. Again, we pick the lower 1/3 because there is less soft tissue and muscle structures to alter or distort our bisection. Okay? So bisection of the lateral, lower 1/3 of the leg. And what's our other reference line?
ground.
Well, Well, it would be the ground, except using my magic hands. No ground.
Fifth man.
Is somebody actually filming this? Because I really didn't want to do that. All right, good. Perfect. I'll see you guys at the residential in-house treatment facility. The Institute for guys that do funny things with their hands and need to be hospitalized. So what's our reference line? It's basically plantar aspect of the foot, right? And it's basically a line from the plantar aspect of the calcaneus extending to the plantar aspect of the fifth met head, which is why we do not distort the fifth met head when we load the foot, because that's our reference line. So if I was going to take this OED, and I'll just place my OED plantarly, there's my reference line for the foot. I'll do it over here for you guys too. There's my reference line for the foot. Plantar aspect of the calcaneus, the plantar aspect of the fifth met. Okay? So we're in essence measuring the amount of dorsiflexion of the foot we get relative to the leg. Okay? So, simple way to do that. I'm going to grasp the forefoot with kind of the butt of my hand here, or the butt of my palm. Pretty much try and go 1 through 4, leaving fifth unexposed, and I'm going to dorsiflex the foot. The nice thing about loading like this is you can maximally dorsiflex the foot to resistance. All right? If you try and do it with your thumb, that hurts, and it's hard to dorsiflex maximally. This way, you get all your body weight behind it, and then once I have that, I'm going to put the subtalar joint in neutral position. All right? And one of the things I want you guys to do is, since we have to put the subtalar joint in neutral position for several measurements, I'm going to come around and work with you guys on subtalar joint neutral so you can really get a feel for what that feels like to have the subtalar joint neutral. Okay? So we load, maximally dorsiflex, subtalar joint neutral, then we take our measuring tool. If I'm going to use, let's say, the tractograph, I'll have one line going from plantar aspect to the calcaneus to plantar aspect to the fifth med head, other line bisecting the lower 1/3 of the leg. Okay? It's easiest to do that with a tractograph. If I'm going to use my OED, I can do it one of two ways. In this case, I'm going to line up the plexiglass with my plantar aspect of the foot reference, and then I will use my protractor and the line on my protractor to bisect the lower 1/3 of the leg. Okay? All right. And then we want to do something else. Once we've gotten the measurement with the knee extended like that, which we want to make sure we do, keep the knee extended, what's the next thing we want to do? Flex the knee, sure. And what does flexing the knee do? We eliminate any gastrocnemius influence, right? So we're just looking at any limitation of dorsiflexion without a gastrocnemius influence, okay? So we flex the knee, same thing. Load, subtalar joint neutral, measure, okay? Why do we put the subtalar joint neutral?
Reproducibility.
Say what now?
Reproducibility.
Reproducibility is one reason, absolutely. Creates a consistent measurement parameters for reproducibility. What was the other reason?
So you don't get the dorsiflexion.
That's true. We do get more dorsiflexion when we're able to pronate the subtalar joint and pronate the foot. But what's the other reason? There's another reason that we put the subtalar joint neutral to check for patient's ability to get 10 degrees of dorsiflexion.
Because in this stance it changes, I think.
I like what you said using the word mid-stance. What is there about mid-stance that might be...
The foot, the subtalar joint neutral at the end, I think.
Okay, so normal gait parameters, we're supposed to be able to get our subtalar joint to a neutral position just before the end of mid-stance. What else is supposed to happen at the end of mid-stance, just before the end? Well, we know heel-off ends mid-stance. That's very true. But what else is supposed to happen just before the end of the mid-stance period, just before heel-off? Subtalar joint should be in its neutral position, and the foot should be able to dorsiflex how many degrees relative to the leg? I'll give you a hint. What was the number we used again to see if someone had coitus? 10, right. Remember, we're supposed to be able to dorsiflex our foot 10 degrees relative to the leg with the subtalar joint neutral just before the end of the mid-stance period. Okay, so that is a normal parameter of gait. Good. All right, doctor, would you mind turning over for me? Remember I said I was going to show you 2 ways to measure equinus. This is the way I personally prefer to do it for a number of reasons. 1, it's easy to keep the knee extended. 2, it's easier to measure your reference lines. And 3, it's easier to load. Okay? And double check to see if you're in subtalar joint neutral. So same thing. If you want to check equinus this way, patient is prone, dorsiflex the foot, put the subtalar joint neutral. The reason I like this is I can verify or get a feel for if I'm in neutral or not by looking at equal concavities medially and laterally. The Achilles tendon and the calcaneus kind of join up there. All right? And then I can get my measurement, I think, much easier. All right? I can bisect my foot, or find my foot lateral reference line, bisect my lower 1/3 of the leg, get my measurement. And then it's very easy to flex the knee, load, put the subtalar joint neutral, and get my measurement. Okay? So I prefer patient prone when I check for equinus. However, sometimes patients can't become prone for whatever reason. Most of the time, unfortunately, in our clinic, it is the fact that they are morbidly obese. So, when in Rome, I don't know how that ties into what I was saying. All right. Any questions about ankle joint dorsiflexion? Okay. While I have my patient prone, I'm going to do subtalar joint range of motion. Okay, that's an easy one. All right. Subtalar joint range of motion. One thing we want to do is we want to have the patient, as we already have him prone here. Remember, you cannot do subtalar joint range of motion with the patient supine. And if I walk into the room and you're trying to measure subtalar joint range of motion with the patient supine, I will tell you this now. There's no way that you can convince me that you can actually do that, no matter how hard you try. All right? Subtalar joint range of motion, patient has to be prone. The other thing we want to do is we want to make sure our leg is positioned in the frontal plane. Easiest way to do that is flex the opposite limb that you're not examining, abduct the patient's leg, and have them rest their foot on the back of the knee on the limb you're examining. That will rotate the limb into the frontal plane. Okay? For subtalar joint range of motion, what are our reference lines? All right. Back of the calcaneus. What, do we want a horizontal bisection of the back of the calcaneus? Vertical, very good. Vertical bisection of the posterior calcaneus relative to what? Exactly, another bisection of the lower 1/3 of the leg. So your reference lines are going to be vertical bisection of the calcaneus relative to vertical bisection of the lower 1/3 of the leg. Okay? Subtalar joint range of motion is probably one of the easiest measurements you can obtain. All right? All we need to do are a couple of things. One, we need to find where the pivot point is for our calcaneal inversion and eversion. Okay? It's easy to do. Just abduct the foot, evert the calcaneus, adduct the foot, invert the calcaneus. Okay? Then we just want to take our measuring device. Okay? I'm going to use the tractograph just for starters to show you because it's easier to find your reference lines and see what we're looking at. First thing I'm going to do is I'm going to adduct the forefoot, which will invert the calcaneus. All right? Put my measuring tool. First thing I'm going to do is bisect the calcaneus, find that pivot point, bisect the lower 1/3 of the leg, and that is my subtalar joint inversion measurement. Okay? In this case, our patient has 22 degrees of inversion. Likewise, I'm going to abduct the forefoot, which will evert the calcaneus, and in turn, that will give me my eversion component. Our patient, oddly enough, has about 10 degrees of eversion. Our patient is remarkably normal as far as subtalar joint range of motion. Considering the knowledge we have of the patient, that's amazing. Just kidding.
He's not.
The patient is, in fact, awesome. Good. So it's real easy. Again, eversion, inversion. Now, another thing you can sneak in there is if you want to see just what the subtalar joint neutral position is, a lot of times when you leave the foot just dangling over the table like that, and you take your measuring tool, bisect the leg, bisect the calcaneus, it will actually show you what the neutral subtalar joint position is just sitting there. Sometimes, not all the time. So you can sneak that in there if you want. But it's very easy. It's easy to use the OED also. Okay? Find your pivot point, line up one line, bisection the calcaneus, other line bisecting the leg, piece of cake. Okay? Subtalar joint range of motion, very simple. Also, while I have the patient prone, I'm going to show you how to do forefoot to rear foot measurement. Okay, and I'll try and show you the simplest way to do it. All right? Remember, what is our forefoot to rear foot measurement showing us? What are we looking at when we get that forefoot to rear foot measurement? What about the mid-tarsal joint? That's true, mid-tarsal joint. Not range of motion necessarily. What are we looking at with respect to the mid-tarsal joint when we check the forefoot to rear foot measurement? Well, that is ways that we may identify different forefoot to rear foot. That is correct. So far you're correct in every statement you said. And why are you guys making her answer all the questions? That's what I want to know. What kind of group are you?
Seriously, Oliver?
Yeah, seriously, Oliver. Where's Oliver? I didn't see you there. Yeah, seriously, Oliver.
What's the question?
I know. What are we looking at with respect to forefoot to rear foot? We know we're looking at the mid-tarsal joint. We know that we can identify if someone has a forefoot varus or a forefoot valgus or a rectus forefoot. But what are we truly observing? We're observing something important. We are using them as a reference, that's true. But what are we looking at when we look at, so far, all good answers. But what are we looking at? Why do we get forefoot to rear foot then? Who cares? What does it show us that we want to know so much?
Abnormal gaits.
It doesn't necessarily show us abnormal gait. It might show us a causative factor.
Is it?
Well, that might be a compensation for one of the things we'd look at on forefoot to rear foot.
Are you looking for like flexible versus non-flexible?
Well, not so much flexible versus non-flexible. You guys have it surrounded. Just pounce. No, not forefoot equinus. Now you're falling. Now you're getting outside the circle of correctness here, as we like to call it.
Structure or function of the character.
No. Stop making me turn around in my chair. I'm going to get dizzy and fall off. And then if someone is actually filming this, that will be incredibly embarrassing. And possibly grounds for dismissal. That's one thing we can see, forefoot varus, you're absolutely right. But what are we looking at? Why do we look at forefoot to rear foot relationship? It is showing us something with respect to the mid-tarsal joint. What is it showing us? It is showing us a specific position of the mid-tarsal joint. In fact, it's showing us the locking position of the mid-tarsal joint. You thought that, right? Unfortunately, I turned off my ESP right before I started this. Damn it. All right, who's thinking of hot dogs right now? You better stop it. I just turned it back. All right. Huh? I know, you're my number one fan. Appreciate that. All right. So, it shows us the locking position of the mid-tarsal joint, right? Locking position of the mid-tarsal joint. All right, so how do we get forefoot to rear foot properly? Basically, we want to lock the mid-tarsal joint while we simultaneously put the subtalar joint in neutral, right? Those are the two key steps. Lock the mid-tarsal joint, subtalar joint in neutral position. Which means we have to load the lateral column, right, to maximally dorsiflex, abduct, and evert the forefoot relative to the rear foot with the subtalar joint in neutral. Now, what are our reference lines when we look at the forefoot to rear foot relationship? Oh, you are filming.
Yeah, no, yeah,
Is that going to be no, yeah, no?
yeah, it is.
Is that going to be on
Just
YouTube?
making sure. Possibly.
All right, so all my fans on YouTube. There you go. It's my one fan on YouTube.
Gotta do a cool backflip or
South.
something.
All right. So what are our reference lines?
I said metatarsal head. You said try.
You did say metatarsal heads. Plantar plane of the metatarsal heads. Very good. What's another reference line? Vertical bisection of the calcaneus is another reference line. And remember, we basically have a third reference line in this that we don't necessarily, we did talk about, but we didn't necessarily kind of isolate as a third reference line. And that's going to be a line perpendicular to the vertical bisection of the calcaneus, which is going to represent, in essence, the ground, right? And that's how we identify if someone has a varus or valgus forefoot, right? Whether or not their forefoot is inverted relative to the line that is perpendicular to the bisection of the calcaneus vertically, or everted relative to the line perpendicular to the calcaneal bisection. That's how we measure the number of degrees if we have a varus or a valgus. Okay? So, it's pretty simple. Now, when you lock the mid-tarsal joint, I'm going to recommend you do it this way. Most people will just load 5th med head or 4th and 5th med heads. I'm going to tell you not to do that, and I'll tell you why. One of our reference lines is the plantar plane of the metatarsal heads. If your thumb is over the 4th and 5th metatarsal head, how are you going to measure the plantar plane of the metatarsal heads? The answer is you're not. Okay? So what I recommend you do is find the 5th med head, bring your thumb proximal to that, just on the neck of the metatarsal, just proximal to the med head. You can certainly load the forefoot that way, lock the mid-tarsal joint, without disrupting the plantar plane of the metatarsal heads. Okay? So my thumb is proximal to the 5th metatarsal head. I'm dorsiflexing, abducting, and everting the forefoot relative to the rear foot. My next step is going to be to place the subtalar joint in its neutral position while maintaining the mid-tarsal joint in a locked position. Okay? Now what you may want to do is you may want to look at the plantar plane of the metatarsals relative to that bisection of the calcaneus before you get your measurement. And I'll tell you why that can be helpful in a minute. All right? So, we've got positioning down. How are you going to measure it? I'll show you how to use the OED first because I think this is the easiest and most accurate way to do it. And I'll show you two ways to do it. One, an okay way to do it. Two, the Dr. Spencer best way imaginable in the whole universe way to do it. All right, very good. How many people are buying that? Show of hands. 3. Perfect. Okay, good. I remember who those 3 were, though. They're going to get A's in something. All right, so I'm going to load the forefoot again, put the subtalar joint neutral. Using my other hand, I'm going to show you 2 ways to use the OED to measure this. All right, 1, you can take the OED, all right, and what you can do is line up the etched perpendicular line here with your calcaneal bisection. That automatically creates a perpendicular with the other etched line down here at the bottom. Okay? But then, this is the harder part. You have to try and visualize or see the plantar plane of the metatarsal heads and line up your protractor with that. Okay? So you find your bisection, take your protractor, line it up with the plantar plane of the metatarsal heads. Hopefully you get a good measurement. Okay? But that's hard. So here's the way I like to do it. I'm going to take my OED, load the lock the mid-tarsal joint, subtalar joint neutral. I'm going to place my OED on the plantar plane of the metatarsal heads. Okay? And then I'm going to use my protractor, and specifically the 90-degree line on the protractor, and move that instead to a bisection of the calcaneus. Allow that line to bisect the calcaneus. Now if I wanted to, I could do this too. I could make it lengthwise and use the long line to bisect the calcaneus as well. Okay? So this line will be the bisection of the calcaneus. This will be resting on the plantar plane of the metatarsal heads. Okay? And that in turn can also show if I have a varus, rectus, or valgus forefoot to rear foot. So I load, lock, place that on the plantar plane of the med heads, bisect my calcaneus,